It is the second series of POPMA Study Club Oral Pathology Stalwart series. And today we have the living legend in the field of oral pathology and microbiology, Dr. Vinay Hazare sir. Dr. Vinay Hazare sir is a pioneering figure in oral pathology whose career spans over 4 decades, marked by groundbreaking contributions to dental education, research, and public health advocacy. He began his career with a BDS from Government Dental College and Hospital, Nagpur in 1975, and further advanced to complete his MDS in oral pathology at Government Dental College and Hospital, Mumbai in 1978, becoming one of the first masters in oral pathology from Mumbai University. His academic leadership is exemplified by a remarkable 20-year tenure as Dean at Government Dental College and Hospital, Nagpur, the longest in the institution's history.
Tribal groups
Currently,
are
he
fighting.
serves as adjunct faculty at Dr. D.Y. Patil Dental
ரொம்ப தூரம்
College
இல்ல. You can't come very often. Once in a year, 6 months
and,
only. Flightல
and
தான் போகணும்.
Emeritus Professor at Datta Meghe Institute of Dental Sciences. Along with that, he has also served as Emeritus Professor at A.B. Shetty Memorial Dental College, Bangalore, and he continues to inspire future generations. Dr. Hazare sir has also significantly influenced the professional community through his role as the President of Indian Association of Oral and Maxillofacial Pathologists and by organizing major national conferences. He is also the advisor of Practicing Oral Pathologists and Microbiologists Association. Dr. Hazare's research has made seminal contributions to understanding oral submucous fibrosis. His work delves into the molecular biology of the disease, explores the role of copper, and pioneers prevention and treatment strategies. Notably, he developed the self-mouth mirror examination method for early detection of oral precancers and cancers, a practice now implemented by the government of Maharashtra. His long-standing leadership of the oral pre-cancer and cancer clinic at Government Dental College and Hospital Nagpur underscores his commitment to patient care. Internationally, Dr. Hazare sir's expertise has been recognized through numerous accolades. He was the first Indian oral pathologist to receive the Emeritus Membership Award from the International Academy of Oral Pathology 2018 and has earned prestigious fellowships from King's College London and American Society, Cancer Society, and John Hopkins University. Honored by eminent figures such as Dr. APJ Abdul Kalam, sir, his work continues to shape global perspectives on oral health and tobacco control advocacy. Thank you so much, sir, for accepting our invite. And now over to you for your presentation, sir.
Thank you,
I
Bhuvan,
request
for
everyone to
that.
keep the videos and the mics on the off mode, please.
Thank you, Bhuvan,
Yes, sir.
for that introduction. Good afternoon, everybody. And without assistance, we cannot, particularly senior people, cannot progress in the field of technology. It's okay. This was a small hitch from my side. But anyway, let's start the study club. And of course, you have named it as Stalwart series. And first Stalwart, we have listened to Dr. Daftari in last series. And of course, I am taking over from him and trying to understand the OSF and PVL, the dual pathology. There are challenges in clinical as well as management and more so on the diagnostics. So let's start my journey. Next, please. Yeah, everybody has seen this in a videograph or photograph during Mahakumbh. Actually, Kumbh is a confluence of, at Prayagraj, there is a confluence of Ganga, Ganges, Yamuna and Saraswati leading to, the Mahakumbh this year. And everybody was fascinated to know that a lot of stalwarts, lot of dignitaries, they have come, including the Steve Jobs' wife. And Lauren Powell had joined that world's largest congregation. So this is a landmark 2025 years. But we actually, it reminded me of Mr. Steve Jobs, who actually, during his Stanford University lecture, one of the best lecture if for the motivational factors. He narrated 3 stories from his life, and he says connecting the dots, love and loss and death. Of course, we know how he died of a severe pancreatic cancer. And he says, you can't connect the dots looking forward. Yes, truly, you can only connect them looking backwards. He has narrated his life pattern in these 3 phases, like newborn, and then life, and of course the death. So, but he really prophesies that you can only connect them looking backwards. So you have to trust the dots will somehow connect you in your future. Have trust in destiny, gut feeling, life, karma, whatever. But this approach is really successful in his journey, and which has made a difference. True to certain extent, though I'm not narrating my life story, but my experience with in understanding the OSF and PVL, I would like to connect the dots. I mean, connecting centuries rather. Next slide, please. Next.
It's being stuck. I think it's stuck, sir. Some issue is there.
Could I?
Sir.
So I will take you to the first slide of rather presentation. And am I audible?
Yes, sir. You are audible.
So I will start my first slide rather with the definition of oral pathology, which has been extremely nicely given by Professor Schaeffer. In fact, that's what I was talking about, the confluence at Mahakumbh of all these 3 rivers, great rivers. But this first disclaimer is that all my clinical cases are original, including this snap, which I have visited in 2004. We can see 2 rivers, Alaknanda and Bhagirathi, confluencing to Ganges at Devaprayag. So, in fact, oral pathology represents the confluence of basic sciences and clinical dentistry. Through the science of oral pathology,
then you have to go for informative.
an attempt
Because
is made.
the segment is large enough, involving lower border of the mandible, only 3 plate of lower border of the mandible is intact, and by doing a intrax segment fixation, you may
Dr.
not
Bhuvan?
give some sort of good stability to that fracture segment.
Dr. Bhuvan?
Yeah, something echo is there?
Yeah. Yes, sir. Dr. Bhuvan?
Yes, ma'am. Please tell.
Yeah, just do one thing. You go to the host and turn off everybody's mic. Mute
Yes,
everyone.
ma'am.
And only leave sirs on. Make sir a co-host.
Okay, ma'am. Speaker switch to. If I make you as co-host, ma'am, will you be able to do?
Yeah, yeah.
It's
Okay.
asking only make host if you are there. I'm
Yeah,
not
I'm here,
able
I'm
to. do that
I'm here. Make it,
one.
no problem.
Rest, okay. I'll just, I think, ma'am, we should continue. I,
Yes, please continue.
yes, yes.
Hello.
Yes, sir.
Yeah, this is a very nice definition of oral pathology, which gives us the, not only the duty of diagnosis, but also a treatment part of it. That's what Professor Schaefer has already given us the responsibility, which we all have to carry. Next. Next, I think. Yeah. So that's what I was telling you, connecting the dots or rather centuries. And for oral submucous fibrosis, we really need to connect from 600 BC or first century to 20th century and now the 21st century. So, it's a long historical, interesting topics which we have covered. So I would like to take you to brief. And of course, PVL is a recent one, but oral submucous fibrosis and an older, like a descriptive matter in even in Vedic literatures. Next, one more click, Bhuvan.
Yes, sir.
Next, one more click. So basically, what Sushruta has said, and everybody quotes that Vidari is a synonym for the submucous fibrosis. But believe me, Vidari is not a submucous fibrosis. It was mentioned by Mukherjee that Vidari is a submucous fibrosis, but it is only a cancrum oris and not the submucous fibrosis. It was in fact in first century, first AD Vagbhat, he calls it as a Vataja Sarasara. And of course, 20th century research and first description by Joshi, then by Damanlal and Schwartz and Pindberg, they all have contributed for understanding. In fact, in 21st century, a lot of research have been done on oral submucous fibrosis. So there is a nice contribution by Indians, including this textbook. Next, please. So Sushruta Samhita says, in fact, he doesn't say submucous fibrosis. It was only a dry mouth, and the use of erica nut or tambul was, not, was contraindicated in dry mouth, but that was not a description of submucous fibrosis. Dry mouth is one minor symptom. Next slide, please. We have searched the literature. As I have told you, Mukherjee and Vishwas in 1972 popularized that Vidari is a synonym to oral submucous fibrosis. But Vidari actually is a disease in which copper-colored swelling occurs in the throat, featured by pricking and burning sensation, and flesh of the throat gets necrosed and falls off and emits fetid smell. No, not a single sign is seen in oral submucous fibrosis. In fact, Vidari is rather gangrenous stomatitis, cancrum oris, or carcinoma of tonsil and tonsillar fossa. So Vidari is a misnomer because there is no sloughing in oral submucous fibrosis. Next slide, please. So there is enough literature, and as I've told you, that Vagbhata's, Ashtanga Hridaya Samhita says, I will read in Sanskrit, Kruchena Vivrunati Mukham, inability to open the mouth, Daha Pittaja Sarasara Ushna, burning sensation in the mouth, Ananta Kafala Mashriya Kapura Buddha, means blanching of the oral mucosa, Tishna Ashaha, intolerance to spicy food, and more so, Durudha or Varna is fibrosis. All these symptoms were described by Vagbhata, so it is more a Vataja Sarasara rather than Vidari. Next slide, please. And of course, these are the 20th century, as I have told you. These people have worked very hard for the understanding of oral submucous fibrosis. Next. Joshi, of course, was the first one, but rather there is always, everybody talks about Schwartz in 1952, that he described these cases. But believe me, in spite of searching the entire literature, we couldn't find the abstract of Professor Schwartz in 1952. But before that, Mr. Joshi, Dr. Joshi, ENT surgeon from the KM hospital, studied from 1949, and Daman Lal in 1953. So I would like to say that don't quote Schwartz in 1952, rather contemporaries Joshi, Schwartz, and Lal has in 52-53 described this condition. So due credit must be given to the original authors. Next, please. These were the dignitaries, Professor Daman Lal and Professor Joshi. Unfortunately, he died very young at the age, I think, 1954, when the disease was described. Anyway, next slide, please. So, Daman Lal's study still stands true. In 1953, he described 20 cases, etiology ericanut, and early, advanced, and extreme cases, which is very true today also. And it is atrophic leukoplakia histopathologically and similarity to the scleroderma. So observation are still valid in modern times. Next, please. So this is understanding of oral submucous fibrosis, definitely improvised by Professor Pindberg and TIFR. Next slide, please. So TIFR contribution is tremendous from 1964 till almost 2000 or 1999. They have studied, and enormous literature is there. In fact, we all know the incidence of malignant transformation in oral submucous fibrosis. The quoted gold standard is 7.6%, which is the outcome of Professor Gupta, Professor Daftari, Murthy, and Bosle's interventional studies. Next, please. So these were the original authors. But as I told you, in 21st century, we all have contributed for the understanding. In this particular textbook, there were 15 Indian authors amongst 21, and this was nicely edited by Saman Varnakula Surya and our own Ranganathan sir. Along with me, Rajiv Desai, Jay Gopal Ray, and most of us have contributed for. So this is how from first AD till now 21st century, the research is going on, the understanding is getting improvised. Next slide, please. Next. Again, OPMDs, there have been a lot of revision, and ultimately we have come down to 2020 classification, that leukoplakia, PVL, of course, which is of main concern to us now today, erythroplakia, OSMF, and oral lichen planus. Remaining lesions are not very important, except oral verrucous hyperplasia, which is a rather cousin of leukoplakia. And there are exophytic verrucous hyperplasias. We have written a consensus report, and that is trying to get that nomenclature we are trying to get in OPMD disorders. Next slide, please. So this is the latest classification. Next. Again, understanding of Tata Institute of Fundamental Research, way back in 1996, they have given that the relative risk for progression is highest for speckled or nodular leukoplakia. You can clearly visualize the clinical nodule, and which of course was a high-risk dysplasia carcinoma in situ. So of course, a lot of research has been come out from TIFR. Next, please. PVL, as I have told you, little recent origin in 1985. Hansen, Olsen, and Silverman, Saul Silverman described this in Western population. Most of the studies are on Western population. It has protein manifestations. It changes clinical and pathological appearances, and interesting side also. It is persistent, progressive. Why is PVL so scary? Because it is resistant to any kind of treatment. The progression to malignancy is very high. Almost 75% of the cases undergo malignant transformation. In Western population, tobacco use is not linked. 63% in Western population, no tobacco. It is with the elderly females in Western population, but in India, it's not so true. There is always a, tobacco association most of the time. Unfortunately, it has a poor prognosis, and we were the one that we described that it coexists with the submucous fibrosis. That's a sort of dual burden of for the oral pathologist to deal with. Next. So these are the classical pictures of what Hansen call it as a multi-site proliferative verrucous leukoplakia. Initially, the verrucous word was there, but Villa in 2018 had deleted the verrucous word. It's again controversial. What we see in our scenario is a verrucous appearance. So rather than calling proliferative leukoplakia, we should still prefer proliferative verrucous leukoplakia. And in fact, Villa has come out with another terminology, erythroleukoplakia, which of course confuses us with speckled leukoplakia or erythroplakias. The only thing is that it can appear flat, it is either verrucous, it proliferates, it recurs, and dysplasia is like a wide range from simple mild dysplasia to even invasive carcinoma. And size concept has been given by Sero Lapendra in 2010, and that's the size has to be more than 3 centimeters when taken into consideration. Maybe you can see that all these projected, they are more than 3 centimeters. Some of them are multi-site, but believe me that in Indian scenario, it can be only one side, especially the tongue. Next slide, please. Next, please. So this you can see clearly proliferative verrucous leukoplakia. On the alveolar ridge, there is a warty appearance. On the palatal side, there is a proliferative leukoplakia. The cheek is also involved, and after some time, the tongue got also involved. So it was a true case of PVL, and incidentally, this case was also associated with the oral submucous fibrosis. I have been observing a lot of oral submucous fibrosis cases with coexisting, diseases or OPMDs. And recently, of course, I have been getting a lot of cases of PVL on the background of OSMF. That's why I wanted, to bring this aspect to the, study group. Next slide, please. So, review of literature, in fact, a lot of Western studies are there. Only, unfortunately, 2 studies are there. One from Manipal Dental College and another from my GDC, which of course we published 6 cases, and Manipal Professor Tenavan and Raghu's group presented 7 cases. That is the only contribution from the India. Next. So these are the criteria, major and minor. Criteria, of course, more than 2 sites, buccal mucosa and tongue or gingiva alveolar, palate, verrucous appearance. Again, it proliferates, recurs in spite of treatment. Histopathologically, as I have been telling, it shows the wide range from verrucous hyperplasia carcinoma to oral squamous cell carcinoma. Next. The minor criteria are also there that shows, next. These are, like at least 3 centimeters when adding all the affected areas. Patient be female and maybe non-smoker. Of course, I have told you, it is a Western, population definition. I will be, explaining our Indian scenario. But anyway, you must observe the disease for more than 5 years. And then, of course, there is a mathematical calculations and we come out with the diagnosis of the PVL. So with this understanding, let's go to next slide. This is a wide range. I have told this is a very common histodiagram to explain different dysplasia changes, invasion, another thing. Next. So of course, chromosomal abnormalities have been already studied And in fact, in PVL also, but not much contribution from Indian colleagues, except I have told you some immunohistochemical studies by Professor Raghu's group from the Manipal. So there is a lot of opportunity to study PVL, especially the, like HPV status. I will be explaining afterwards. Next slide, please. Next, please. Next. See, this
Sir,
is
next.
Yeah, next you can go. Skip this. So this is classical multi-site. You can see on the left buccal mucosa there is a warty appearance, and right buccal mucosa the dysplastic or erythroleucoplakia. So size is definitely, when taken together, more than 3 centimeters, and it was of course a mild dysplasia when we excised it. Next. So these are few clinical cases which I am going to narrate to you or demonstrate to you. This is, you can see the submucous fibrosis, and there is a verrucous hyperplasia. You can see the extent and size. It is also spreading on the lower lip along with the left, right buccal mucosa. Of course, these are all tobacco chewers or erica chewers or erica quid chewers, and this was excised. Next slide, please. Which we can see the clearly histopathology. Next, click again. Next, click again. So this is, varicose hyperplasia. So now the clinico-pathological correlation is PVL. So these are very simple cases which I came across in initial stages. Next. So this is what I was thinking. PVL of course makes it interesting not only for the malignant transformation. Almost 75 to 80% of the cases undergo the malignancy, but it also coexists with the OSMF. And then there are recent concepts of treatment, that oral metronomics chemotherapy, which I have been having little empirical evidence. That's why I wanted to bring this to your notice. Next. So etiology, of course, OSMF, definitely erica nut. PVL, unknown etiology, Western population not associated with tobacco. HPV status is still not proved. And this is the study from Manipal group. Next, yes. Let me explain the Manipal group study. They have nicely conducted immunocytochemistry. And you can see the age range, 60 plus, male to female ratio 1:6. Tobacco habits, as I have told you, Western population, not much, but at least 50% of Professor Raghu's cases were, having tobacco habits. Multicentric involvement. All 7 cases had multi-site, multifocal, and 3 cases turned into malignancy. But important message from Professor Raghu's study is that they have conducted extensive immunohistocytochemistry, and if you see that all 7 cases were intensely positive for the COX-2. And there is a logic to use selective inhibitors of COX-2, and that may be useful in PVL. So COX-2 inhibitors like celecoxib can be used, and that's what I will explain you during the oral metronomics chemotherapy. Next, this is the only Indian study, and of course we did extensive studies. Believe me, this was a long-term followed up studies. Unbelievably, the follow-up ranged from 5.5 years to 13 years. All 6 cases were personally observed. Multiple biopsies were taken by me, and unfortunately, in spite of the treatment, all of them have died. And in fact, malignant transformation, they died of malignancy with the, in fact, some of them having shown the metastasis. Here also tobacco habits 5 out of 6. So definitely tobacco habits play an important role in Indian scenario. And one more thing I would like to emphasize, tongue may be the only site. They always talk of multi-site, multifocal, but even on the tongue, it can change the site and size also from left to dorsum to the right side of the thumb. So that should be considered as a multifocal because tongue is such a larger organ. Next slide, please. So these two studies are really, this we recently published a paper and we have found out or documented that 4 of the 6 cases associated with the oral submucous fibrosis. Next. These are the few cases. This lady, 73 years and no habits in my cohort of 6 cases. The only lady, the only patient who has no habit. You can, next slide, you can see how, next. Yeah, you can see on the right palate and unfortunately within the 5 years of span, this patient died, including having the malignancies. Next. So this was again the other quadrant where we can see the PVL. Next. And third quadrant. And this is multi-quadrant involvement. You can see all the 4 quadrants are involved. And in fact, palate is also involved, which is clearly seen in well scope examination. Next slide will show you the well scopic pictures. You can see the palate. There is a verrucopapillary growth. All the other 3. So this was the patient treated with surgery and other thing at our college, and in fact, one of the oncosurgery center also. Next. And to start with, it was only simple verrucous hyperplasia. You can see 2013, it is very mild, typical verrucous hyperplasia. But in 2016, it has progressed to well-differentiated squamous cell carcinoma, and it was subjected to surgery. And next slide, please. And the palate, it reappeared, and in fact, on the palate, the lesion was sarcomatide carcinoma, very aggressive. Unfortunately, in spite of surgery, radiation, patient died of disease within a span of. So this is how PVL, when it turns to malignancy or CA, has a poor prognosis. Of course, she had no oral submucous fibrosis. Next patient. So this is the patient, second patient, another, that's what I was telling you, only on the tongue, but you see the clinical range on the upper flow, upper row, that it keeps on, migrating from the left side. It came to the dorsum of the tongue. In fact, it was treated and healed up also. But over the period of follow-up, there was a small nodule on the dorsum of the tongue. And after a few years, on the right lateral border, you can see clearly the clinical appearance of the CA. And on tongue, dorsum of the tongue, both the verrucous as well as invasive squamous cell carcinoma were there. It was also treated, but ultimately patient died after the follow-up of 13 years. Next. So this is very, another patient, again, you can see on the tongue only, but how diffuse. It from the left side, it went to the floor of the mouth, it went to the palate, it went to the other side, involving all sides of the oral cavity, and there was a metastasis. So these are the cases which really have poor prognosis. She also died of the metastasis. Next. So these are few cases which I wanted to show you. And you can see now our medical management is definitely, I just want to emphasize besides antioxidants and curcumin in the preventive or the treatment part. oral metronomics chemotherapy is a new concept. One more click, Bhuvan. Lycopene is, of course, low cost effective. Next, curcumin is also being used. But newer perspective, that's what I wanted to explain you. Oral metronomics chemotherapy. It's a given by, concept is given by Dr. Banawali from Tata Memorial Hospital, Mumbai. Next. Next. So it's a oral metronomics chemotherapy. Before that, one slide earlier. So how it, it's a combination of, it's a combination of high dose of celecoxib, COX-2 inhibitors, which I was explaining during Professor Raghu's study, that and low dose of antimetabolites like methotrexate, 15 milligram once a week. This is a oral rather than any systemic. It's a oral tablets are very cost-effective tablets. This celecoxib you have to give for months, 2-3 months, and it's a 200 milligram twice daily, and 15 milligram of methotrexate once a week. You must observe the patient for 3 months, and then of course take up your call whether it is regressing or recurring or static or progressing. Next, of course, we must do the biopsies also here whenever the patient comes to us. Next. Next slide, please. So how it works? It's a combination, as I've told you. It works by direct inhibition of the tumor cell growth. Of course, antimetabolites will definitely work. It also works on the activation of the immunity, and it works on the principle of inhibition of the vasculogenesis and angiogenesis. So this is, of course, a safe dose, which has been already tested by Tata Memorial Hospital Group. So I also tried this. I will explain you. So this is about the oral metronomics chemotherapy. Next. So these are the few cases. You can see the dorsum of the tongue. Size is more than 3 centimeters, only site. And you can see the mild dysplasia very clearly. Next, this patient was long-term followed up by me. So I have the full details of this patient. Next slide, please. So this is our histology, the protocol. You have to take the hematological workout and biopsy. Definitely you must judge whether it is a high risk or low risk. And the schedule I have told you, methotrexate and celecoxib, you can give it for a month, then rest period for 1 week, and for review it regularly once a month, and you can continue till 3, 4, 5th, and 6th month. If it doesn't regress, take up the biopsy or go for the surgical arm. Next slide. Next slide, please. So this was the same patient which we started, of course, that mild biopsy, mild dysplasia. Then you can see this is a stretched tongue. There were reddish lesion and small 2 erythropapules were there. And we dissected or took the biopsy. It was, you can see the coelocytic dysplasia. Maybe human papilloma virus because of the coelocytosis, but we couldn't progress, with HPV determination. So this was, we started giving him oral metronomics chemotherapy. Next. Yes, these are the 2 small lesions. You can see one whitish and another reddish. And we did the biopsy, definitely. And because multiple biopsies are being done in PVL, so treatment was also undergoing. And see the slide, histopathology result. Next slide, please. Was, high-risk dysplasia. You can see the mitosis more than 10. It was in fact carcinoma in situ. Just the like we did the pass and other thing. Basement membrane was intact, but otherwise this was like carcinoma in situ, or what we call high-risk dysplasia. And again we continued the treatment with the metronomics. You can see the next slide. Next slide, please. So it regressed. Those small reddish and those papules, they regressed. Only a minor stump remained, and that was a rudimentary stump showing the excellent healing. And that was also biopsied. That small stump was biopsied. You can see the histopath. Next slide. It is only a proliferative with a mild coelocytosis and mild dysplasia. So definitely from that 10 high power mitotic fields per high field to hardly any mitotic field. So this is what I thought oral metronomics chemotherapy is working. So these are the cases which gives some empirical evidence. Next slide. Of course, the patient was from an adjoining state and he was being followed, but he didn't come for the biopsy. He discontinued oral metronomics chemotherapy, and you can see sandwich in between both these teeth. There is a squamous cell carcinoma, which was so early when you can see the hardly there is a invasion. So this was squamous cell carcinoma because patient stopped the metronomics being from other state. Next, he was also operated, and very nicely he was operated, but during COVID years there was no follow-up, and whatever we gained by early diagnosis, early treatment, we lost the patient because that was a COVID scenario. In fact, he had a lot of metastasis in flap, lungs, and different sites. He of course was given palliative chemotherapy, but again died. Almost 5 years follow-up. I started following up from 2017, and 22 he probably lost him. Next slide. Next, please. So this is how PVL, when it all our 6 cases, I explained you the range. Clinical was simple leukoplakia, erythroleukoplakia, maybe like multifocal leukoplakia, nodular, and some of them were associated with the, like SMF. But if you see the status, almost all of 6 of them died in spite of giving best of the treatment, which is in fact done in National Cancer Institutes also. So this is the worst scenario of oral submucous fibrosis and the PVL. Next. But there are some good cases, successful cases. If you see the dorsum of the tongue, this girl has only a small patch, homogeneous leukoplakia, more than it went on progress to, like in 2019, this was the clinical appearance. Next, when she came to me in 2022, next slide, please. So this was what is, Villa called is erythroleukoplakia, but I would definitely call it as a, proliferative verrucous leukoplakia. This was the appearance. Size, of course, more than, of course, it has the definitely the squamous cell carcinoma appearance or the histopathology. Next. So she was treated again. Next slide, please. So one thing is that you have to take multiple biopsies, and somehow you come across at like diagnosis of cell carcinoma. Of course, she was treated by surgery and radiation. Next slide, please. So it ran, of course, you can see the dysplastic features or small malignant. The flap restoration, invasion was so radiotherapy was advanced. She was treated, next slide, please, by surgery, radiation, and constant follow-up has led to wonderful recovery. Next slide, please. So this is during operative stages. I personally attended the operation in April 22. Next. Wonderful work our plastic surgeons, they do, oncosurgeons, they do. See, last week only, she had come. You can see the healed up scar. She has no fibrosis, no habits, and whatever little fibrosis was there, radiation fibrosis or post-surgical. She is now leading a very recurrence-free life, So her name itself is a prerna. So these are all small cases that really inspires us to take this big fight against cancer and play whatever role, diagnostic, management, or treatment in such cases. Next. So that's what Dr. Daftari says, Dr. Hazare, you have an empirical evidence because that is, based on observation or experience. But he also told me that define these things and do the pilot studies. That's what I wanted to be percolated among study group. Those who are PG guides, they can, take up this oral metronomics chemotherapy and PVL studies, and really we can serve the purpose of study group. Next. So ultimately, this is our algorithm. We with lasers or the scalpels. If they are non-risky, we do the follow-up. But that's what, especially in PVL, I just wanted to advocate oral metronomics chemotherapy. I will show a few of the cases now. Next. So this is again, you can see 33 years when she came to me. And believe me, I'm not lying. They all are personally monitored or followed up cases. She has submucous fibrosis, multi-site, you can see on the lateral border of tongue as well as on the left buccal mucosa. She was exclusively Erica nut chewer and also cleansing the teeth with the snuffs. So when it was biopsied, next slide, it was only mild dysplasia. You can see, but there was recurrence within a year. It is mild dysplasia, but the recurrence. So next, when she visited me, next. So this was the state that again it persisted. In fact, proliferated. You can see the verrucoid appearance or the warty appearance. So next, we started giving her oral metronomics chemotherapy. And sometime, if you see the center, there looks to be a slight resolution. So OMC follow-up showed little bit of resolution of the, those warty lesions. Next. So we continued with the oral metronomics chemotherapy. Next. As I told you, frequent biopsies are important to judge. This was only mild dysplasia, so we continued rather than getting totally excised, and follow-up must be there. Next. So you can see within 2-3 years, it resolved. There is a clinical regression. If you see on the lateral border of tongue on the left side, there is also improvement of mouth opening. So this is what is, I call it as empirical evidence. She is leading a satisfactory life, but constantly taking medicine, she stopped taking medicine. And of course, she came for the follow-up. Follow-up next. And what we saw, This is resolution regression. Next. Next. Clinical regression in 5 years. But when I saw her last, again the lesion recurred. So this is very typical of PVL. It recurs, it doesn't regress. So that's what I wanted. Because patient discontinued OMC since last year. She was tired of medication. Naturally, leading a very successful housewife, she thought, enough is enough. But, I convinced her to start some other alternative medicine treatment. So let me, observe whether OMC has really worked. But again, my point is that multi-institutional pilot studies are required. Next. So this is a recent case. You can see on the palate, looks verrucoid. On the buccal mucosa, arrow also show that he was a submucous fibrosis patient, and all this PVL with the submucous fibrosis. Fortunately, there was no invasion, and I was quite sure this is not CA, which was clinically diagnosed by one dental surgeon in remote places. Next. We did the biopsy. Next. We did the cytology. We should do the cytology, especially for the HPV, liquid-based cytology. Next. Liquid-based cytology for high 16-18 came negative. Next. So this is workout. When you see the clinical case of verrucopapillary lesion, do the liquid-based cytology, do the histology, do the HPV types, do the high-risk dysplasias, and then, of course, with biopsy and saliva-based test, diagnosis, and of course, treatment and follow. This is a workflow for the verrucopapillary lesions. Next, especially PVL. We did the biopsy very freshly, 18th of February. You can still see the verrucopapillary growth on the palate and the buccal mucosa. Nice healing, clean biopsy, good biopsy was done by my oral surgeon. Next. And it showed simple hyperplasia, verrucous hyperplasia. There is not even invasion, there is not even dysplasia. This is simply pseudoepitheliomatous hyperplasia. I called it as a verrucous hyperplasia, though the lesion looked very, to inexperienced eyes. This is what we wanted to, emphasize. Next, simple verrucous hyperplasia. It healed up also. You can see and this is clinicopathological correlation, OSMF with PVL. Next, he is still under the follow-up, and maybe next week he is coming, giving me a sweet dishes and other thing. Next. So we have to, do our job to make them real correct diagnosis. And of course, as I've told you, treatment is also our duty. Next. So there looks to be good healing within a week. The palate is healing. Maybe next week I will, share another photograph of 2 weeks healing wound. Next. So this small lesion, gutka chewer with fibrosis, you can see the speckled leukoplakia. In circle, we started oral surgery. We did excise for the purpose of biopsy. Next, and it was, next slide will show you that it was a well-differentiated squamous cell carcinoma. So we were thinking it could be only, high-risk dysplasia, but the invasion was already there. So patient being from, poor, he was resistant for any further surgical management. So we gave him oral metronomics chemotherapy. Next. And over the 3 months follow-up, you can see the lesion has, again, rudimentary stumps are there, a good, excellent healing, and patient is still on the oral metronomics chemotherapy. I am observing them once in a month, and good for the patient. Maybe I will do the MRI to get the exact status of the soft tissues of the fibrosed and the excised surgical margins. Next. This patient, of course, see within 3 months of the oral metronomics chemotherapy, if you see left side, there is definitely Varti lesion, speckled leukoplakia, and which regressed. Of course, she also has a submucous fibrosis. So I'm getting a lot of cases. So I'm just observing them with the.
You should have one more.
I think this is the last slide, which next patient or next. So it shows definitely, and that's what I want to conclude that, increased malignant potential of PVL, need for management of dual pathologies by newer therapies such as oral metronomics chemotherapy, and long-term follow-up is really must. Because PVL is of unknown etiology, still HPV status is not clear. In Western, it is not associated with tobacco, but in Indian, we have seen Indian, their scenario is with tobacco. OSMF is definitely Erica nut, no chili business, no hypersensitivity, and no other things except only oral submucous fibrosis and Erica nut. Next. So this is Indian scenario I was telling. Maybe the different, and that is true as a failed cancerization. PVL can occur on submucous fibrosis. It recurs, and definitely it is associated with the tobacco habits in Indian scenario. But we have to publish the data from different institutions. Maybe study group will have registry of PVL cases. To start with, I can about 16, 17 cases which are on my files. I can give it to the study group. Next. So this is how we have been telling or learning about oral submucous fibrosis, and really believe me, all these are original things I have explained to you. My original concept or experience on the submucous fibrosis, and again I come back that follow-up is must. See, 2004, I first visited that Deopraga and saw the confluence. During our Dehradun conference, me and my mentor, Dr. Daftari, we again revisited. So revisits are really important. Follow-up is really important. And you can, believe me, you can have a long-term follow-up, like when I can follow it up for 13 to 14, 15 years. Why not? Again, I come to that Schaeffer's point. The oral pathologist's duty is to diagnose properly and treat adequately. Maybe we are on right path with the right mentors like Dr. Daftari and my many mentors, and definitely my students. They are more important. In fact, Dr. Ruchi, who is listening to our lecture, she has popularized the curcumin concept in submucous fibrosis. And we did a lot of multifactorial research on oral submucous fibrosis. So next, I think that was concluding slide, or next slide, please. Yes, and I am grateful to all patients. They have been very, very cooperative. My mentors, Dr. Daftari, Dr. Professor Saman Varnakula Surya, my colleagues, Karishma Desai, Dr. Supriya Keur, Dr. Abhay Datarkar, all my postgraduates. I could not have presented a single slide without their, involvement, and all my postgraduates. I'm really thankful to them. And thanks to POPMA for giving me this opportunity. And yes, that's, I think. Yes, Bhuvan, I'm done.
Yes, sir. It was an excellent presentation, sir. It was eye-opening, and all the cases were marvelous. And with such a long-term follow-up, which is sometimes does not happen in our scenario, but it should be done. And really, hats off to you, sir. And I'll take some questions and a lot of good wishes, sir. Excellent
Yeah,
presentation.
plenty of students
So,
around. So,
yes. Dr. Nidhi Yadav ma'am, she has a question that till
Yes.
when should the metronomic chemotherapy be continued if the lesion has clinical and histopathology wise too?
Basically, this is the philosophy of Tata Memorial Hospital. In fact, operated cases also, they keep on continuing because it has proved its worth. It works. Uh, Even after surgical excision, radiation, patients are kept on oral metronomic chemotherapy, and it's really helpful, especially in oral submucous fibrosis or oral potentially malignant disorders. I think we should try it first 6 months. If it is not regressing, and then do the surgery. Definitely don't wait for to become it invasive. And I will have tried it for like 2 to 3 years. You have seen the patients, but they themselves are like reluctant to take a long term treatment, because mine is only experimental or observational study. Had it been pilot or strict protocol study, they had to take. So maybe 6 months, check the biopsy. If they are not progressing, take again for 6 months. If they are progressing in duration, another thing. But if you, then of course you must do the surgery or lasers or other treatment. But if you have seen few of my cases, they have shown static, or they have not regressed. They have not become like aggressive. So we are in a safer zone. And the antimetabolites which we are giving is a minimal dose. Celecoxib also, these are all tolerable dose. So I think we should continue for 6 months to start with initially. It's a cost effective. It's a cost effective also. Another point, because patients will not, take expensive medicines. And this is the oral form of metronomic chemotherapy. Definitely, our dysplastic cells will not budge to anti-inflammatories. They really need antimetabolites and COX-2 inhibitors. That is my understanding, and that's what we should be, proving our hypothesis for this empirical observation.
No,
That's what Dr. Daftari wants me to do.
yes. And what about, sir, in cardiovascular cases? Because now celecoxib they are now contraindicated in such for kidney failure cases or kidney injury and CVS cardiovascular system. So, what will be the best alternative? Because they have chances of more heart failure because of celecoxib. So,
Yeah, that is, celecoxib. One thing is, it is nephrotoxic, and cardiotoxic. I know the toxicities, but get a proper evaluation done by the physician. So my patients definitely do the entire, echo findings and ECG and complete cardiac checkup, because I just not only hematological workout, but also the physician's consent is, and of course the cardiac status, and of course with the different blood investigations we come to know. At least once in 6 months, the complete investigations, blood investigations at least to be
has
done.
to be done.
But whatever the dose, it's a tolerable
Yeah,
dose. That's
it's a
what I have
tolerable one.
literally.
Then I have this question, sir, that there are so many cases where habit was not there in PVL. So, what, in your experience, what is the probable etiology for PVL, sir? Is it HPV in Indian scenario, or is it immunocompromised status?
Yeah, let me explain with some of my clinical observations. That lady I showed you, multi-quadrant involvement,
Yes,
and the palette, another thing, well, scope picture I have shown you. She had no habit, and
yes, sir.
initially I thought it's a lichen planus, because of the clinical appearance, and multi and burning sensation is of course very common. She had no submucous fibrosis still. I treated her with the, intralesional steroid for some time. She responded. But when, we took the biopsy, it was really verrucous hyperplasia that, low. So then we thought, no, this is PVL. And in fact, Professor Saman's article that we skipped up, because of the technical hitch and other thing. But all these PPTs are there. You can just analyze. Please go through all the literature relevant. And he says PVL could be mistaken, or lichenite dysplasias and lichen planus-like lesions could be, earlier hallmarks of the PVL. And lot of very good, that particular article is available with me. So HPV status, definitely not many of our, even my, whatever I have done, 5-6 cases, no HPV status have been, maybe we have a high resistance for HPV viruses, maybe genetic. So we are strong enough to, but this is a very loose statement. We need to study the HPV status, maybe with the PCR based technology. This was of course PCR based. That's what, and that is liquid based cytology is giving an important understanding of. You all have known the liquid based cytology. So let us learn what is oral pathology. We have to learn from some other branches of the pathology or some medical sciences. We are learning liquid based cytology from pathology. We are learning oral metronomics chemotherapy from oncologists. So this is how really that definition must be our, it should be displayed all over the institutions. I find some institutions displaying Schaeffer's definition. So really students get motivated, or we get motivated.
Correct.
So my experience says it's still multifactorial, but in Indian scenario, definitely tobacco is playing a role. So
Yeah.
let's see.
Only
Because we
for
have
those cases which where habits were not there. There I was a bit curious to know the exact
not
cause.
many studies. I have told you, Professor Raghu has 7 cases. I have 6 cases documented. 13 cases. It's not good, to draw any conclusion. So we have to study the Western literature. That's plenty of. In fact, professor which she had come, Wu, Professor Su Bin Wu, she is doing on extensively on PVL. So we must collaborate with them, especially for the PVL. Many people have liked the concept of oral OMC, but not people from our own country. They are not many colleges. They are coming with these pilot studies.
So hopefully, sir, people will incorporate this part of yours, and everybody will be benefited.
Adverse drug reaction. Nowadays, each we all have to face the inquiries by adverse drug reaction.
Yes.
So that's because I also learned through one of my patient had a little allergic reaction. So I was asked by that company about adequate, adverse drug reaction. So we are learning, we are understanding all these diseases.
Anybody has any further question? I think no question is there, sir. I'll share your.
On Bhuvan, I'll say a few words.
Yes, sir.
Yes, sir. Yeah. Good afternoon, sir. Most welcome.
Good afternoon. Well, as expected, as always, he came out with a really nice presentation detailing all the nitty-gritty of the clinical cases of PVL with fibrosis, and with a very, very proper follow-up and proper observation. It does bring out the general understanding that oral cancer is an issue in our country, and we need to see that we take care of it. Now, when Ackerman must have initiated this varicose hyperplasia, varicose carcinoma, there was always a difference in the definition, but very correct on the histopathology of hyperplasia. Now, with the submucous fibrosis, some of the added things are happening, and one really doesn't know it's become a kind of a multicentric mucosa, where leading to some of these kind of changes. But this multi-sectoral observation can be made only in India of these kind of things. I only wanted to ask Vinay Hazare, with all these exhaustive investigations and clinical understanding, was Canada ever done? Canada positive? And second, and the most important part of the thing, that today, Dr. Nagpal himself made an observation that no habits. Now, this is another situation that we have been facing lately. As I told you, the study from Hubli, which said 25% of oral cancers have no habits. Now, that's a large figure, but we have to accept the fact, since that figure has not been either collaborated or sort of no similar studies have been undertaken. So all these expected lesions which is happening in the mouth, they have a probability of an important diagnostic criteria, but the important preventive aspects also. But this no habit occurring in his case, as you said rightly, would make us feel that there has to be some similar, even retrospectively, if some of us can go through the files of oral cancer cases and find out whether there are no habit groups have been so large as expected or as reported. But Dr. Hazare said very clearly why all cases come to him. Maybe he's a brilliant guy, so all cases go to him only. That's what he said. Anyway, I congratulate him for having taken the step further from pre-cancer to cancer, and is continuously doing his commitment to oral pathology. And his definition is correct that you learn from everybody. And I congratulate him, and I congratulate you also for having coming out with this tolerant series and coming out new observations and new cases. Thank you very much. It was a lovely afternoon, and thank you.
Thank you, sir.
Thank you so much, sir, for your kind words. Your presence meant a lot for us.
Thank you, sir. You only have given the answer in your publication, Temporal Role of the Tobacco.
Yeah.
So we need to read, all of us need to read the particular article.
Yes.
And no habits, of course, you were telling me, trying to convince me, but I am convinced there are, cancers without habits. Especially, I have showed that 28 years female, she had, of course, no habit, and she has only acid reflux. When I discussed with Professor Johnson, she said acid reflux is a good indicator. It induces the inflammation. It induces it's a good, it's a not at all carcinogenic. So there are cases, maybe some
No,
of them is a PVL in true sense, and let's work on those non-tobacco cancers also, equal importance.
I'm accepting it has been there many years. Cancer is intrinsic to begin with. If you understand the fundamental principles of cancer, cancer is intrinsic. And the tobacco habits or any habit triggers it or brings the cancer forward. But by far and large, if you look at the fundamental cancer, natures of cancer, the cancer is intrinsic, occurring within body itself. And therefore, as you said, if you're going to get a cancer, you probably will occur. Tobacco habit either triggers it or does not allow the cancer to come forward or postpones it if no habits are there. That's the theoretical part of the game, but only important part of the game, the 25% was the one that I was looking at it. Not thinking is very clear. Cancer does occur without habits and is as expected because being an intrinsic in origin cancer. So that's part of the game. But whether it's 25% or no, that's what I just wanted to know because we have published a paper, Temporal Role, which is time associated role. It is not necessarily happening immediately. So that's just an observation. And others can do the similar work. But thank you very much once again. Enjoyed it.
Thank you, sir. Thank
Thank
you.
you.
Yes, Bhuvan? Any other questions? We can.
I think we lost that connection, sir, in between.
No, Bhuvan.
Today,
Yeah, good. Dr. Daftari, gave us those insights. And
Yes, sir. Am I audible to you?
yeah, I am. Am I audible? Okay, just to conclude, I think this was the constant mentoring by Dr. Daftari, and naturally this is time to go and visit Mahakumbh. I mean, Kumbh. I mean that Ganges was a confluence of two rivers. If we go to Prayagraj, there is a confluence of three rivers. So let's go and more in a positive direction towards the wisdom. And thank you, Bhuvan. Make one small announcement that anybody who is to, contribute and for the understanding of PVL or for the registry of PVL, I am ready to, be associated with it. And thank you all my postgraduates now who all are heading the departments. Please take up this pilot project on OMC. Thank you.
Yes, sir. Sorry for the interruption, sir. I think, am I audible now?
Yeah.
Yes, sir.
Okay.
Sir, would like to present a small token of appreciation uh, for your enlightenment, and on behalf of POPMA and the entire team of Oral Pathology Advocacy Committee, we express our deepest gratitude and admiration for your contributions and unwavering commitment to the profession. Thank you so much, sir,
Thank
for
you,
being
Bhuvan.
a guiding light and inspiration to all of us.